At the community level, it means building stronger partnerships between health, police, local authorities, education, housing, justice, and the voluntary and community sector. At the service level, it means ensuring that universal services such as general practice, maternity and mental health are equipped to identify abuse and respond safely. And at the individual level, it means recognising risk earlier, supporting victims and survivors before harm escalates, and developing safe pathways for those displaying harmful behaviours so that they can access appropriate services. Steps to Safety is one practical example of how we are putting that prevention-led approach into action in the NHS. Steps to Safety is a key area I've been focusing on in my role as the DHSC's Board Advisor. It is a referral pathway from general practices into specialist support services for victims and survivors of domestic abuse and sexual violence. It represents an important opportunity to strengthen the NHS response to violence and abuse. It is designed to ensure that GP practices in every area of England can connect victims and survivors with specialist services. By 2029, we hope there will be national provision. The model has three core components. First, specialist training for GP practice staff. This will go beyond general safeguarding training to help all staff develop the skills and confidence to identify domestic abuse and sexual violence, respond appropriately, manage disclosures safely, and make effective referrals. Second, access to specialist domestic abuse and sexual violence workers. These practitioners will support general practice teams and provide specialist intervention for individuals, including safety planning, risk assessments, and advocacy. Third, stronger connections with local specialist services. This, of course, includes domestic abuse and sexual violence services, but also housing support, mental health services, substance misuse services, and specialist organisations supporting minoritized groups. Importantly, Steps to Safety is intended to build on existing local provision, not to replace it. We know that there is excellent work already taking place across the country. Our aim is not to duplicate services, but to strengthen those local systems and increase access to support. The model is also intentionally broad and inclusive, recognising that people affected by violence and abuse may present in different ways and at different stages. That includes adult victims of domestic abuse and sexual violence, adult survivors of child sexual abuse, children impacted by domestic abuse, healthcare staff, of course, themselves, who are often the very first users of a service like this, and adults displaying harmful behaviours who may be at risk of perpetrating abuse. The programme is developing at pace. Integrated Care Board applications for the first phase closed last month and are being reviewed. As Steps to Safety develops, it will be accompanied by national evaluation so that we can understand what works and we can continue improving the model in years to come. Prevention must be ambitious, but it also has to be honest about implementation. We cannot simply announce programmes and assume they will change lives. We need to understand workforce pressures, commissioning realities, local service capacity, and the experiences of victims and survivors. One of the strongest messages I've heard from specialist services is that identification without adequate support is not enough. If we ask more victims and survivors to disclose their abuse, we must ensure that there are safe specialist pathways for them to access. Otherwise, we risk raising expectations without providing help. That is why partnership with the voluntary and community sector is so central. Specialist domestic abuse and sexual violence organisations hold expertise that the health system simply cannot replicate. They understand risk, trauma, advocacy, safety planning, cultural barriers, and the realities of recovery. Crucially, they're often independent from statutory services and therefore trusted much more than any of them. A stronger health response must therefore be built with, not around, specialist community services. It must also be inclusive. We know we need to improve access for groups who too often face additional barriers to support, including Black and minoritized women, survivors with disabilities, LGBTQ+ victims and survivors, those with multiple disadvantage, and people living in rural communities. A health approach that does not address inequality will not succeed. Looking ahead, my ambition is for a health system where victims and survivors are identified earlier, where staff feel confident and equipped to respond, where specialist support is available when people need it, and where services are designed around lived experience, evidence, and partnership. I truly want violence against women and girls to be understood as core health business, not an optional add-on, not something that only safeguarding teams think about, but a central part of prevention, women's health, mental health, children's health, maternity, primary care, and neighbourhood health. Once I met a survivor as part of research that I was doing for a domestic abuse charity called Safe Lives. And she said that she disclosed her domestic abuse to a doctor, a consultant in the emergency department where she had gone. And she said, I really need support. Her abuser had seriously hurt her and broken her bones. And the consultant said to her, I'm sorry, we only do bones here, not that relationship, mental health sort of thing. So she was patched up, her bones did heal, but she went back into the same relationship and the same danger. And when we spoke to her, she said, if only he had said, there's a way for you to get out of this, she would have left so much earlier and not endured the very painful years that were still to come. And I will carry that story with me because I don't want that situation to happen to any other woman again. The NHS reaches millions of people every day. That gives us a profound opportunity, but also a responsibility to recognise harm earlier, to respond safely, and to make sure that no victim or survivor is left to navigate the system alone. Steps to safety is one important part of that ambition, but the wider challenge is bigger than any single programme. It is about building a health system that sees violence against women and girls as their core business, that works confidently with specialist services and local partners, and that uses evidence, prevention, and lived experience to change outcomes. If we get this right, healthcare can be more than a place people come after harm has happened. It can be part of the system that prevents harm, opens the door to support, and helps women, girls, and children, and men, live safer, healthier lives. So thank you for all the work you're already doing, and for the partnerships we will need to make that change real. Thank you.
Thank you so much for that really inspiring talk. It was brilliant. Are you ready?
Yeah, if there are any.
Any questions from the room? One of the only chances you'll
We'll lady up there.
Thank you, yes. Are you okay projecting? Yeah.
Yes, there's obviously a lot of evidence that domestic abuse increases when somebody becomes pregnant, or any domestic abuse that has been present may escalate in severity. So it either starts or it escalates. One of the things that I know that we're very keen to do in the Department for Health is to try to start to unpick some of the reasoning behind that. So we know that it happens, but there hasn't necessarily been a huge amount of research into why. And within the feminist sector, we have a number of views about that, particularly in terms of, you know, the mom developing new bonds and attachments and love with the baby either to come or the baby who's just been born. But we don't necessarily understand how that fractures. We also know that there are some hormonal responses that men may have in relation to, you know, their partner becoming pregnant. We don't know whether that is something that then also imbalances relationships. So I think getting the research right and understanding the reasons for it are very important. But obviously, what we ought to be doing is to get the response right. Now, of course, within midwifery services and in maternity care, we do have routine questioning, but we know that it doesn't work very effectively. So we know that midwives say that they don't actually feel particularly well equipped to open the can of worms, as they often describe it. So they may rush over the question. I certainly know that when I was pregnant and went in, I think the question was about whether I felt safe at home was squeezed between a medical history of diabetes and you know, whether I was sleeping at night. There's probably something, I think, to be said about how and when it's asked and the training that midwives do. Having said that, of course, many midwives do get positive disclosures and will often do a really effective job at safeguarding that woman and her unborn child. But clearly, I think there's a lot more that we need to do in that process. One final thing is that we did a multi-site evaluation of hospital-based independent domestic violence advisors over about 10 years ago. I did a policy report called Cry for Health. And we found that where you co-located IDVAs, so specialist domestic abuse professionals, within maternity or within emergency departments, often they would straddle both. You did get an increase in disclosures and you got an increase in support. And often the increase in disclosures was much earlier in the domestic abuse relationship than it would have been in the community setting. So we compared the data from the hospital disclosures of the length of abuse to data sets of survivors being supported in the community. And we found it was around 6 months earlier, which actually is incredibly important when you think about how many victims and their journey and we might be in. So I think this idea of having those specialists co-located so that you as a health professional can refer into them like you would do for bloods or any other specialist in the hospital, and just to make it part of a pathway and a normality, really, that once you get that disclosure, you're not left holding what can be a really, really dangerous situation and one which you may feel as though you have to spend all weekend finding a refuge. Well, that's not your job. That's not what you're trained to do. And you need to go and meet other patients too. So my view is if we could expand that across maternity, that would be a very good step.
I heard this was a festival, actually, and I loved it drumming with it during lunchtime. So I largely wanted to celebrate who we are and what we are doing. We're a multidisciplinary workforce in public health. We do lots of things. I sat next to a nutritionist, a lawyer, but I think we've all got the same mission. So I briefly wanted to talk about who we are, what we do, and obviously where we should be going to. It doesn't go forward. I hope it goes forward. I think one of the skill sets we should have in public health is how to use these machines after those years. But in Tahzib's celebration, this is the Manchester Festival of Public Health. And as I was walking down the streets, there are huge things to celebrate here. The man who saved Manchester is not the one who's on the train, by the way, to London today, but this was the headline of the biography of James Niven, one of the early chief medical officers, and he's entitled The Man Who Saved Manchester. I wonder whether a new one will also save the world as well. He was the first medical officer to enforce preventative measures. He made TB a notifiable disease. And one of his major impacts in Manchester was during the Spanish flu pandemic. And if you look at some of his guidance he gave, it's exactly like COVID. Very, very well written. Unfortunately, he committed suicide. He walked in the sea and he committed suicide. But a lot of his other work is on slum clearances, improving standards of housing, sewage, refuse disposal, smoke pollution, a real public health leader of his time, celebrated globally. And obviously Manchester It was the first NHS hospital. I'm wondering how many of you are aware that the first NHS hospital in the UK was in Manchester on 5th of July, 1948. And this is quite a big, for people who come from overseas, from Canada and elsewhere, the NHS is a religion here. And this is when the early temples was built in Manchester. The world's first IVP baby was also born in Manchester, Louise Brown. But one of the things I've been reflecting on this early history was that the public health people were always persecuted, and they felt trouble, and they reflected on their own identity, who they were, including, if you look at Niven's report as the first medical officer, he often wondered, what on earth am I doing with so much opposition? With the permission of, I just wanted to share with you a very brief 1 minute, 30-second video. Let's kill out the killjoys. This is in 2017, where public health budgets were just beginning to cut. During the austerity, for those people who come from the thing, the public health budget in the UK was cut between 18 and 20%. And there was a debate on a posh news channel, Newslight, about this. Michael Marmot, very distinguished public health people, said, we want more money, don't hurt us. And this is a health economist who went to give his bit about what it should be.
Here it was all about the first time in the century, controversial second classes. Sure, there was the needs of that. Or staff, it was concerning back. Never in history, that's reason. And that is a big fun without some more. Endless fight, let us say, the direction. And suddenly, how do you for our collective regular? Thank you. Together then, as it seems. Well, then, never really about health. Last week, this whole question keep alcohol, cigarettes, sugar drinks, all and almost popular with ordinary working people, reality well. I was talking about really just selected in the whole line of sense, failure to that's something. Yeah, the new breed of Pearsons is being funded through taxation. That's network, state funding busy. This was very we say Britain is becoming the joyless.
Busybodies, moral entrepreneurs, I think often working in a local authority, often there is, particularly with certain political parties taking over as a local director of public health, they want to have smoking again in local authorities and so on. I'm just wanting to reflect with you, Abraham Lincoln, in his famous House Divided speech, when he was lobbying against stopping the slave trade, he had a very, very clever approach to this. And he said, if we could first know where we are going, we could better judge what to do and how to do it. So in the next few minutes, I just want to reflect with you, where are we in public health? Where do we want to go to, and how are we going to get there? Big questions about every aspect of public health. We should perhaps be moral entrepreneurs, because these questions ultimately are moral questions. For the past 40 years, the UN has talked of an inflection point in history. And Antonio Guterres, in his Common Futures document, noted that we are at an inflection point in history, humanity faces a stark and urgent choice, and that the choices we make or fail to make could result in breakdown or in a better future, a more peaceful future. The important learning point for me is the choices we make or not make. We have a choice about what sort of public health people we are and the choices we make as public health professionals, what we stand up for and what we don't stand up for, and for what reasons. In fact, a lot of politicians now have talked of inflection points in history, and today's Bastille Day, which is often referred to as an inflection point, July 14th, Revolution Day in France. An inflection point is a critical transformative point that causes a sudden, irreversible shift in trajectory of society, technology, or politics, a decisive turning point where the future becomes fundamentally different from the past. The railways, the Industrial Revolution, AI will never go back to where we were before. COVID, perhaps, has been referred to as an inflection point in history. But the important point to remember is that inflection points are a time of change where we have a choice. Railways are not a bad thing. AI is not a bad thing. Therefore, Charles Dickens, who was writing about the French Revolution in his book, Tale of Two Cities, described it as the best of times, the worst of times, age of wisdom, the age of foolishness, the echo of belief, the season of light, spring of hope. We're all familiar with this, but I think it resonates with me at the times we live in. The wonderful opportunities with AI. We develop the vaccines. We do so many wonderful things in public health. Yet some of us, during the tea conversation, there was a little bit of a despair. So this is all because we are at an inflection point, and we need to make the right choices of how we make them. For leaders of the Lancet, there's a new Lancet Commission on Activism and Health, and they launched themselves last week. They didn't use their inflection point, but I think they were referring point that the old world is dying. In other words, if the steam engine comes in, the old way of horses and all that is dying. The new world struggles to be born. Now is the time of monsters. And I'm sure many of you have discussed who these monsters are at this particular time in history, creating conflict and confusion because they're refusing to accept a new world order and the inflection point in history. Historians often talk of events, battles, Bastille Day, but revolutions are not, events do not fall from the sky. Revolutions happen for a reason. And with our public health people, we often look at environments which cause these events. What causes their revolution? What is causing the inflection point? And there are two terms which has been in the press quite a lot. One is the polycrisis. In other words, there's climate change, there's conflict, there's inequalities, all sorts of things seem to happen all the time. There's a war in Gaza, the bombs that are driving, it's driving climate change and so on. And all these are entangled together. There's also the term metacrisis, which I think public health people, we have a lot to contribute to. The foundational root causes that generate the polycrisis, including how we see the world, our economic systems, and the way we see and understand reality. I just attended a seminar on misinformation, and there was a wonderful explanation that we need to understand how other people are seeing the world. It's not how we see the world in the West as colonials, but it's how the reality, how do we see the truth? And it's not a simple thing we as public health often think. We generate the numbers, and that is the truth. So the polycrisis is the symptom, and the metacrisis is the disease. I just want to go back to very basics in the last few minutes, because we often trot out this definition of public health, science of art of preventing disease, and as our wonderful chairman this morning, Sanjay, we often forget it's through organized of society. And that's what distinguishes us from, I think, other people in terms of public health. And since the style doesn't go forward anymore, I don't know what else to do, but it moves forward. I think last year, the Faculty of Public Health has spent a year discussing what is public health. And I would strongly recommend, particularly for international commies, to look at these 6 dimensions of our profession and what questions we need to ask. Who is the public? What makes health public? What is the limits on collective action? Who's responsible? These may sound at 4:30 on a long day, very philosophical, but I think they're very, very practical issues we need to consider. It's ultimately in public health, we need to balance out relations between the state, the individual, and organizations. It's not as simple as doing brain surgery. We need to understand the limits, duties that we owe each other as human beings, and to what extent we accept the role of the state, and so on. I'm currently quite interested in ethics, as you know, and I think this is actually a moral mandate in public health. And moral mandates involve obligations. We have an obligations because we're paid money to do this, to care for well-being of the society. But at the same time, we have a power, and it's how we exercise that power which gives us professional credibility. This was a headline paper in Liberia during the Ebola outbreak. And I'm wondering what you see as a headline for this. Ebola outbreak, Liberia. The headline was, this is not public health, this is violence. Because this is not how we do public health. We don't send soldiers out, although it is done in some parts of the world. We don't consider it, at least in many countries, as being the civilized to do. The other thing is, we love our statistics and our epidemiology, and we often get in public platforms as, let the evidence speak for itself. And we share this bundle of wonderful numbers, which we spend years doing PhDs on, which are very, very important. I'm not saying they're important. I know I'm in an academic environment which loves these numbers. But do facts truly speak for themselves in science? The answer is no. How come Trump looks at one set of facts and someone else looks at one set of facts and they come diagrammatically opposite conclusions in terms of the things? Facts do not speak by themselves in science. It is us who interpret them, who ascribe meaning to them. The other big question is public health just science? And it isn't. As public health family, we have a set of values which often drive us. We want to save the world, we want to create good health, and many of us come in public health because of the values which we ascribe. And a profession is actually defined who has three attributes: education and training, knowledge, and also adhere to ethical standards. And I'd be shocked that actually ethics is often seen as a side, it's a thing on the side. We've done for the last 15 years survey of public health people, and 58% of them come out of their 5-year education without any training in ethics. For the last bit, I just want to reflect for the last few minutes on our learning from the pandemic. It's our most recent experience where there was a stress test of the health system. Do you remember the early days of the pandemic when the Chinese came to Milan? They rolled out the carpet, they bought all these things. We're all waves of 1C as doctors and nurses, they used to clap for us on the streets and bring us cakes on the streets. And they did do this, by the way. I know they're skeptical, some young people who may have not experienced this. We certainly got cakes. And within a year, everything turned upside down. In the States, paint was being daubed on people's homes. A lot of public health people, 64% of the public health workforce in the UK had moral distress and injury because of policy divergence of politicians versus what you want to do. And a little bit on the side, just for entertainment, in 1848, in the Times, which is a posh newspaper in the UK, they said, we don't want any of these nanny state people because the public health people want to ban sewage being thrown out to the top windows, down the street. They said, this is not really good public health. And the Times said, let us get on with it. We don't want, what did they say? Force givators to all these commands of sanitary bailiffs. So this tension between us and authority is not a new thing. The other issue with respect to is technical miracles and moral catastrophes. We developed the COVID vaccine, but Dr. Tedros said the COVID pandemic was a moral catastrophe. It was a moral catastrophe. The northern people got all the jabs. Thousands of people, millions of people in the world didn't get it. It was certainly a moral catastrophe. In terms of learning from it, some of the learning, integration of ethics into policy decision-making was one of the key learnings with WHO. Practical implementation of solidarity and social justice. We often use these terms. What do they mean in actual policy in public health? and professional institution capacity building. The final thing with the pandemic was the person who won the Pulitzer Prize for exploratory reporting on his coverage of COVID-19 was a journalist in Atlantic, which is quite an intellectual paper. And he won the prize because he said how public health took part in its own downfall. The field's future lies in reclaiming parts of its past that we're willing to abandon. Public health was criticized by intellectuals for good reason or bad around not doing this part. This critique, of course, is nothing new. Richard Horton, in his editorial of Public Health England and others, he wrote an editorial. There was a time when public health I should have probably missed out the country, was driven by passionately articulate values, when its leaders concerned about social reform and political change. Public health is the science of social justice. It's time for those leaders to discover courage and purpose. This is about us. It's a family meeting here. We're celebrating our goodnesses. We really need to reflect on this critique coming from all around the world and what it means moving beyond technical solutions. What is our moral mandate as public health people? In a UNICEF, UNDP, World Bank review of COVID and Ebola, cost $6 million, the review of them. Their conclusion was our past failures must be understood as moral failures. And we need to commit ourselves to a set of values of solidarity and global justice. So in terms of our response to the polycrisis, one of the questions Professor Michael Marmot always says at the beginning of his lectures in 2 years, one is about neoliberalism. The other one is, we always ask the critical question, what sort of a society do we want? How often do we debate what sort of a society do we want as nutritionists, as lawyers, as whatever we are? This is fundamentally an ethical question, I think. The other key issue is we need to reflect on our collective worldviews, our cultural paradigms, economic systems, and the way we see the reality. I'm actually a bit surprised that we're spending our time talking all this about informatics and all that, which is an important issue. There's going to be a special supplement of European Journal of Public Health, but it's fundamentally around how we see reality at this time. Are we all seeing a chair? What are we all seeing around the world? And Elena Pestelos, who will be sleeping, and she's chair of the EUPHA Global Health Committee, and we do need a global health ethic. The SDGs, we're only 36% of the things that are currently done. Why are we not talking them more about in public health? Because this is our broadest mandate. Policies need to be shared on shared humanity, and that we basically live on one planet with one people. And to just finish, I think Derek Wonders, who was a banker, it's near his anniversary, and I went to his funeral. You know, in 2003, he gave us, for public health, 14% more budgets. Inside the report was this quote from the first woman doctor in the UK. It's a lot of numbers inside, but I think the bit inside is we're not tinkers who merely patch what is broken. We must be watchmen, guardians of the life and health of our generation, so that stronger and more able generations to come. So I hope we can have conversations within our family more about these sort of non-technical issues, because unless we get these non-technical issues right, we're really not going to do anything with the numbers at all. Thank you.
Hi, everyone. Maybe we can also turn up, I don't know if it's gonna be hotter if we have a little bit more lights. So I'm Tina, and yes, so I actually usually introduce myself as a public health practitioner first. And during the COVID pandemic, I had the privilege to actually work at WHO headquarters in Geneva when we basically started looking in a more systematic approach about challenges with rumors and health misinformation during health emergencies. And I actually wanted to basically, through this talk today, just to give you maybe 3 things or 3 takeaways that I guess I wanted to share with you from my experience working as a practitioner, and I'll tell you a little bit more throughout my talk. But what's interesting, and all the way through today, it's always interesting to actually come to a conference, a meeting that is very local, grounded in public health practice and research, because it literally oozes and shows through the conversations during the day. So I actually kept writing onto a little bit of my outline of the talk that I made earlier, all of the different quotes of people from the keynotes and throughout the day that I was hearing, because actually a lot of things that I wanted to say won't be new to you, and I realized because of all of the things that I heard. But hopefully you'll still find my take a little bit interesting. So, you know, my background is, I started my education, my career as a health informatician. So I was the data nerd who, you know, worked with evidence and health information. And what's interesting is that throughout my career, as I continued working, I kept going back to, well, what I want to understand better is actually people and the context in which they live and work and play. So I naturally, even, you know, as an information scientist, I went into the human aspect of evidence and use of it and public health systems, even though, you know, I'm very much still involved in evidence generation and translation. So one of the first things, if we talk about one of the big lessons learned for me as an information scientist, someone who worked in health information and in digital health before the pandemic, when I started working on, when I was tasked, okay, well, what can we do about health misinformation and how we can help countries to deal with this during the pandemic. The first thing that I learned was that information ecosystems are actually all about relationships. It's probably the big thing that I've been repeating since the pandemic, although a lot of the public discussion and frustration and, you know, concern about harms concentrates on misinformation, on false information, and all of these types of concerns. But what I've learned and realized is that in public health, still now, like in pockets of our institutions and in how policies are being made, we still rely a lot on, you know, the working model. We have the knowledge and we need to give it to the people to use. And when there's gaps, we give them a message. And that addresses the issues when it comes to why people don't use evidence in their decision-making about health. And that's definitely not the case also from what we've heard, you know, throughout today, even this morning in the keynotes, right? We know that people work through what their health means to them, very personal level. And it depends on in their relationships and discussions with their family, in different social circles that they belong to, also online, etc. And so that also means that if we, that kind of conversation and how people then interpret health information, health guidance, advice, that happens outside, so in between visits to the health system. And this is a big challenge for the public health system, because you've heard probably, and you've read it also in the media, we're very proud that people still trust health professionals. Okay, but do we need to, are they the only people that should be solely responsible for making sure that people are informed and making decisions? If we know that people might never actually either have access to health services fully, or there might be all kinds of barriers to actually discuss health information with people. So one of the things that stuck with me, you know, when we're thinking about misinformation, or the reason why we should be talking about information environments, information ecology, is how people are actually making sense of things, is because mistrust in the end isn't the problem of the public. It's actually, an outgrowth of perception that either promises were violated or values were broken. I think it was the councilman this morning in the keynote that someone mentioned that local communities here in Manchester, when they were talking to them, were mentioning that their trauma was being farmed. And we have a lot of responsibility to be sensitive and to actually understand where people come from. Like one of the examples when people come to me and we speak about, we need to address misinformation, we need to fight it, it's a battle. Well, think about it this way. Chronic Lyme disease communities, for example. These are communities that have been created by patients who experience symptoms of Lyme disease even after antibiotic treatment. There is no evidence in the literature that there is such a thing as chronic Lyme disease, but patients come together to give each other support, validation of their experience, and information. And that is not an easy, like a group of people to now accuse that they are propagating or believing misinformation. We need to actually understand what are all the different failures along the way and the mistrust of the mainstream healthcare that actually led, for example, to communities to form and support each other. And then, of course, there's also information and discussion of evidence that is differently discussed and differently received than, for example, a scientific community discusses chronic Lyme disease. So one of the things that I often say is that, yes, of course, it's important to make sure that we correct false claims, etc. But if we focus all of our efforts in chasing false information online and trying to correct it with another claim, right, we're actually not addressing the wider context within which people experience health services, preventive services, and the relationship with health guidance and with the health system that contributes to mistrust that makes it actually quite difficult to have conversation about evidence. So this is one small piece regarding this. In a sense, basically, you could say that evidence moved through relationships, right? One of the speakers earlier, I was just drafting was mentioning you need to quantify the unquantifiable, right? One of the keynotes. And this is really important. The second thing that I wanted to just suggest is that if we're thinking about relationship, it has a lot to do also with how we think about relationships, not just with the community, but also within our own systems that we build. So I'll give you an example. Like during the pandemic, one of the very common asks within WHO is, okay, we need to organize trainings for frontline staff because this is the best way to translate current evidence, current tools, and disseminate it globally and get people up to speed. So it was basically a pipeline for dissemination of information. But really what came out of that was relationships with people from all over the world who were actually in the front lines responding to the pandemic. We had people who were not only responding to the pandemic, but at the same time battling hurricanes and floods and wildfires and all kinds of things. But all of those relationships actually remained, and that community of people, over 1,400 of them, what they taught me is that those relationships actually endured not just the pandemic or the guidance, because it was changing, but also sometimes even the institutions. And we don't really emphasize enough the importance of relationships that we build within public health systems, not only with the community. That also means valuing different profiles of staff. My current work, a part of it deals with actually working with frontline workers, not just community health workers, but different staff that works at the interface between the public health system and the community. And we tend to understand them as the last mile of delivering a service or a program. They're actually the first mile of understanding what is actually happening in the community, in addition to actually working with the community. So I actually went back to school specifically because I thought that at local and city level, so the work that I'm doing is in New York City Department of Health and the communities, the neighborhoods in the city there. I specifically went back to school because I realized that a lot of the local action meets at local and city level in the community, because health then interacts, and I don't need to tell you, with education, with schooling, with housing, with transport, etc. So one lesson learned for me is that we haven't been able to articulate, and we need to time and again be able to articulate the value of building relationships, because a lot of times, like a finance colleague would put all of the coalition building into the budget as a cost center, meaning it's an expense, it's a dissemination expense. And we don't actually value it as a value generating activity. And then the third point, if I just add on to the coalitions, we talked today through many different parts of the program about social, commercial, structural determinants, because we know that health systems, public health systems cannot actually address all of the determinants of health by ourselves. And what we do need to remember is that the answer isn't just any coalition and involvement or consultation of the community. I was very inspired by the example, Arpana, that you are doing with the council, Manchester Council, because there's two things evidence tells us, but also I think the practice, and we need to make sure that we practice and more students actually learn about how to do this. Coalitions fail when power is actually not redistributed as well. Many times as a practitioner, I have observed in situations where communities were consultants but not actually involved, and it has a lot to do with how decision making is done and how the communities are involved. And the second part, which is also important, so I'm originally from Slovenia, small country on the continent, but I currently study in the US. There's all kinds of differences in language and concepts, public health practice, many different parts, not just in the States, but also globally. What is really important to understand is that sometimes in public health, historically, we have sometimes tended to be quite purist in who we will collaborate with, because we need to have shared values in order to build a coalition. Actually, coalitions can be really effective when there's shared interest, which means that we build coalitions across different groups of people who might not agree on everything, but they have a shared goal in order to address a particular challenge related to health and well-being. And we need to really be able to do that better going forward. So the point here is that trust, and we speak a lot about trust building, etc. Trust doesn't usually flow to the channels that public health controls. And it's very uncomfortable to actually have to build relationships and understand that we actually don't have control over the 80% of the social determinants that was also mentioned this morning. Here's all the quotes. So yes, these are the slowest to build, but obviously the potential to change is really great. So we really need to be thinking about this. So in our previous session, Shannon was actually saying, one of the presenters, that relationships are infrastructure. And we really need to be thinking about this, whether it's value, how we actually organize ourselves. But It is going to take the next generation of public health practitioners and everyone that is raising them now to actually address this and teach this. So I usually end my talks with, well, what can you do on Monday? And some of you might be still students, others are practitioners, other researchers. Consider speaking to someone outside of the usual public health circle that you speak with, whether it's cross-sectoral or someone else, that you've been avoiding, because this is really important in order to start understanding and building coalitions. Because really, and if we come back to the misinformation piece, our job isn't to get better at telling people about health guidance or what they need to do. It's actually, we need to get better at building and maintaining relationships with people. And that really is the lesson for me from the pandemic. Thank you.
Mine's for welfare. My day job is as one of the directors within UK Health Security Agency. Very pleased to be here to deliver Marco Petrick Memorial Lecture. Marco was a consultant in communicable disease control in Manchester, a TB researcher, and a very kind and generous colleague who absolutely modelled evidence-based practice. And in preparing, well, first of all, disclaimer, I'm a director in EUPHA. I'm not talking as a director. These are my views. They're not the views of EUPHA, His Majesty's government, or anybody else I'm associated with. But in thinking about this, I was thinking about response, because I spend a lot of my time doing incident response, and that our operations are much more visible than the research and the evidence behind them. Operations, you do a thing, or you don't do a thing, is quite obvious. The evidence, which, whether it's there or not, is less visible, and often there's an awful lot of effort in the background to try and work out what the evidence base is and continue to build it. And this has been a bit of a journey we've been going on. We now explicitly start to identify in our responses all the things we don't know. That's actually quite an uncomfortable place as a theoretical expert. I'm now going to publish everything I don't know. We started off by talking to researchers and research funders about it. We now increasingly publish it. So in most of our technical reports, we have a list of research questions, which is a polite way of saying, this is stuff we don't know. So I just want to talk through a couple of recent case studies with just a few of the questions that we were considering in response, and how we went about trying to address some of those. And you can tell I haven't spent a lot of time preparing for this because these are really recent examples, so these are the top of my mind. So 13th of March was a Friday. The team in the Southeast, which is one of the teams I look after, identified a case of invasive meningococcal disease. That's quite common. We see 300 to 400 cases of meningococcal disease in England each year. So they managed that in the usual way. On a Saturday evening, they had a series of phone calls that continued into Sunday. And over a 48-hour period, there were 15 cases. So for something where you see across England normally one a day, seeing 15 cases in 48 hours is truly exceptional. And even in terms of outbreaks of meningococcal disease, most of the ones we see are between 2 and 4 cases, and often they're in families or very, very close contacts. This is really unusual. And most were cases from the University of Kent in Canterbury, as well as, or 6 from students, and rapidly identified a shared exposure at a local nightclub. And this is extracted from the Euro surveillance paper, but this is where the initial investigations got to. 21 confirmed cases of type B invasive meningococcal disease, epidemiologically linked, and they are all sequenced as type 485 part of clonal complex 41/44. And that's the subtype there. That probably doesn't make a huge amount of, we'll come back to that in a moment in terms of what that actually means. In terms of visibility of the response, this was incredibly visible. We gave out over 13,000 doses of ciprofloxacin, which is the antibiotic we use as antibiotic prophylaxis, and over 11,000 people received a dose of Bexsero vaccine. That actually hides quite a lot of initial investigations and research. One, we need to make sure that this is actually sensitive to ciprofloxacin, and two, we need to make sure that the actual strain was covered by the vaccine. Usual epidemiological investigations, and that's our social network diagram, focusing on the nightclub and the university and all the different links between people. So our big question is why did this happen? This is odd. Really tragic situation. Young, fit people become severely unwell. They were all hospitalized. We had 2 deaths. So we came up with thinking about what's going on here. What's the drivers? And this was our basic approach. Has something happened with the bug? Is there something about the individuals or the population affected? Or is there something about the pathway between them? Is there some behavior or environmental factor that's changed something? For those of you who are doing masters, that's a pretty simple approach to it. This is dressed up, but this is very much looking at the pathogen, the pathway, and the receptors. And that's what we did. So we investigated the bug. And it was different from what we had previously seen. It's in a clonal complex, which accounts for about 40% of it. But if you dig down into it, and sorry, on the tree, the red dots at the top are the ones we're looking at. This is actually quite a distance away from anything else that we're seeing in England. And those are the closest ones. So, and if you, so I think this was, what did you say? Yeah, about 90 genes differences, 90 mutations differences from anything else. So there is something different about this. What does that mean? Don't know. Because we then have to try and work out actually what's significance. Does it mean that it's more transmissible? Does it mean it's more virulent? Is it more likely to send you to hospital? So this is certainly one of the factors. And one of the things is, okay, are we going to see this anywhere else? Are we going to see further transmissions of this? What does this mean? So all of this gets published. If you are particularly into geeky things like me, you can go and look up all of these sequences. We publish them, we share them. And that's not just because we are incredibly generous, but it's also a way of getting every other researcher interested. If you put the information out there, we can actually get the collective mind behind us to actually really understand what this means. We thought it was, the bug has changed. There's probably a combination of different factors in there. This means that it's resulted in an outbreak. But that's probably not the only thing that's going on. Our other question was, has actually the immunity in the population changed? Is something different? Everybody starts to talk about, has something changed post-COVID? Is there something about this generation of young people with different exposures? Did 2 fairly simple things. One, we can actually take some blood samples and look at antibodies in them, but also, it doesn't explain why Kent, why then, because we'd expect immunity to meningococcal disease to be fairly consistent across the country. So this is probably not the main driver of this particular outbreak, but it's something we need to try and understand, keep an eye on, and consider as we're designing our control programs, including our vaccine control program. That takes us on to our third hypothesis. Was there something different that happened in club chemistry? what happened in that nightclub and in the university that resulted in this super spreader event, this large outbreak. I have to confess here, I am not the expert on clubbing. Do not ask me what is normal in clubbing. So that's why we had to get some people who get the involvement of our behavioral scientists working with our epidemiologists to investigate this. This is about knowing what the right questions to ask was, trying to understand the behaviors. Again, we didn't think it was that likely there was something truly different happening in one particular nightclub in Kent than anywhere else in the country, but we wanted to investigate that further. So there's initial epidemiological investigation and a follow-up cohort study that's doing. And one of the difficulties is trying to do these things fast enough. So this is coming back to one of the other points of trying to pre-prepare a lot of this research. Some of it you can't pre-prepare because you don't know what the risk factors you want to investigate are, but making sure you've got the platforms to do the research, you can rapidly do it, because the opportunity to do it is at the time. These people forget, the other things get in the way. They're much more likely to answer your survey if they're in the queue to get their antibiotics than if you send it to them 3 weeks later. They'll also much better memory of what they were doing at the time. So we worked through our sort of drivers. We then started to think about actually what else does this mean? So one of the questions with meningococcal disease is who's carrying it? It's quite common to carry meningococcal bugs without causing disease. So actually we've started a prevalence study to understand the carriage within the local area with the possibility of doing it wider to really understand what the carriage of meningococcal disease, meningococcal as a bug rather than the disease is, because you can carry the bug without ever getting the disease. So trying to understand that carriage. This all links back into what the control program is. So to make this as up to date as possible, on Monday, the announcement of the time-limited MenB vaccine offer for anybody starting university as an undergraduate for the first time in autumn. So that's as a direct response to this. In parallel to that response, further work and review of the evidence by JCVI to determine what the future of meningococcal vaccine programs will look like. So big response, huge amount of evidence behind it. And this is dealing with something we know quite well. We do meningococcal disease a lot. We've got very successful programs that's against different strains. Outbreaks used to be common. They're very rare now as the success of the vaccine program. But the work needs to continue. And this is something we're familiar with. But we still have a lot of questions. Recognizing that I've got -5 minutes, we'll go on to something that we weren't very familiar with, something really different, which was hantavirus. So hantavirus is a virus predominantly carried by rodents, and you normally get infected by contact with rodents. One particular type of it is Andes hantavirus, New World hantavirus, relatively recently identified, or in my head, 1995, which is when I started university, is very recent. And it causes a serious cardiopulmonary syndrome and is predominantly acquired from contact with pygmy rice rats. You can rarely get human-to-human transmission of Andes hantaviruses. Most hantaviruses don't have any human-to-human transmission. Andes hantavirus is unusual in that you do get human-to-human transmission, although it seems to require close contact. Normally seen in Argentina and Chile, we see it very rarely in the UK, and we manage it as an airborne, high-consequence infectious disease. So a highest level of control within the NHS, we do it. I put up there long incubation period up to 42 days. Actually, that's what we got to, that's what we think is the right answer. It took us a while to try and work out whether that is the right answer. That's the global agreement at the moment, but on a limited evidence base. It's quite important though for control. If you want to isolate, want to quarantine people as potential contacts, you have to do it for up to 42 days since their last exposure. So knowing that is quite important for response. You may remember some of this, but it's a very rapid version of this outbreak. That is MV Hondius, which is quite a smart cruise ship. It set off from Ushuaia in south of Argentina, and I'm not sure I've got a pointer to try and describe this. That will work. No, you'll have to put up with me pointing then. So it set off. It went to South Georgia, right down the bottom here, which is one of the UK overseas territories. That one's uninhabited. It went up to Tristan da Cunha, one of the most isolated places in the world. And we'll come back to Tristan in a moment. It carried on up to St. Helena. Along the way, not that long after leaving Argentina, one of the individuals on board became unwell and died. Tragic circumstance. The ship carries on and its cruise until they arrive at St. Helena. St. Helena does have an airport, and both that body and their traveling companion, left the ship at that point and were flown to Johannesburg. Case 2, which was the traveling companion, became unwell and then died very shortly afterwards in Johannesburg. The ship in this time had carried on to Ascension, so went up to the next UK overseas territory, and we've got somebody becoming unwell again, and they get medically evacuated from Ascension to South Africa. So we started off with a death on a cruise ship, which is not that uncommon if you think about the large numbers of people and the demographics of those who go on cruises. But now something unusual is happening. On 26th, 27th, we've got both the Chief Medical Officer of St. Helena, Chief Medical Officer of Ascension involved. We've got a relationship with both of those because they're UK overseas territories. And on the 1st of May, we start to get involved. And a day later, we reported to WHO that something funny is happening. And it was literally, we think we've got a really odd outbreak on a cruise ship. Don't know anything more, but we can give you the heads up. Team in South Africa confirms that this was hantavirus from case 3, and the same day a 4th case dies. And a day later, the ship arrives in Cape Verde. This is an unusual disease, and this is now a truly international response because we have got, it's a Dutch flagged cruise ship. It's got multiple nationalities on board. It left Argentina. It's been to UK's overseas territories. It's got cases in South Africa and is now in Cape Verde. So really quite complicated. And this is back to points about public health as an international community. Lots of conversations early on, open sharing of information. And that's been really critical throughout this. Because there's lots of uncertainty, this is not something we've seen before, and that collaboration was critical. I'm not going to go through all of the rest of the story in the interest of time, but this was the overall outcome in terms of the number of cases. So 13 cases, 3 deaths, and onsets over quite a prolonged period of time, recognizing that we know there's a long incubation period. Right. So we had lots of questions at this point. How does this normally transmit? Can you be asymptomatic and transmit? How long are you infectious for? What's the best way of treating these people? Should we be giving something for post-exposure prophylaxis to look after the contacts? And we've got a lot of contacts. Most of them on ship, but in other places. What should we do with everybody on the ship? And this is our first list of questions. So questions about the virus. Is this something different? Is this the Andes we've seen before? Again, virus has been published. Questions on how is this spreading? We don't know a huge amount about human-to-human transmission of Andes hantavirus. There's one outbreak in the literature which we focused on. We actually put the Dutch put an epidemiologist on board for the journey between Cape Verde and Tenerife. And as a good example of asking the questions at the right time, they went around and interviewed everybody to try and understand the transmissions. We were still slightly worried about animals. Are there any rats on board that are contributing to transmission? If we bring back people to another country, are they going to infect our rats? And getting the vets involved to assess the risks to rats, and then as well as our work on how to interrupt human-to-human transmission. We don't know a lot about the clinical characteristics of this. There are pre-existing research platforms, and this is an example of using one of them. So this is using the ISRIC clinical characterization protocol in something called NAVA study, where we're actually a 21 country collaboration to try and understand this and understand the clinical characteristics and how we best treat them. Favipiravir was suggested as a possible treatment. There was a supply in Liverpool, which was meant to be being used for a trial in another country, which got repurposed. And government of Japan kindly provided oral favipiravir for the trial of post-exposure prophylaxis. So some rapid trials going on at the same time. So we're learning a lot very quickly. However, I'm predominantly an operations person, not a researcher. So there's some operational challenges. We had a sick person on Tristan. You cannot fly to Tristan. There is no airport. There is no, you can get ships into there in calm weather, but mostly it's small boat transfers. Because we had a sick person and there was potential for them transmitting to all of the healthcare workers on the island, everybody who looked after them, we asked our friends in the military, how do you get somebody in quite quickly to Tristan? They said that was fine. So this was their plan. They normally drop in pathfinders. So this is 16 Air Assault Brigade pathfinders who said they'd quite happily drop into Tristan carrying supplies, including equipment. And if any medics wanted to go too, they'd just strap them on. So we couldn't find any parachute-trained intensive care doctors that were available. It's quite a niche role. So I actually don't know whether that picture is of Toby, who's the anaesthetist, or the ICU nurse being dropped in because they're upside down in full kit. But that's how you get them in. We did ask them how they're going to get them off again. So we had to redeploy the Falkland Islands Guard ship, which went on a round trip of several thousand miles to go and pick these people up afterwards. But equally, we didn't quite know. We had to do a bit of work as to how you treat hantavirus. What did we want to drop in? Because we only had one opportunity to drop things in for several weeks. In a more pragmatic thing, we repurposed Arrow Park Isolation Facility, which was famous at the start of COVID, and operated that with lots of questions about how do you isolate people safely? How do you get people to comply with isolation? How do we get them to want to be isolated? 42 days is a really long time to be shut up anywhere. So some really interesting behavioral science work coming out of that. This looks very boring, but this is fantastic success from my point of view. There wasn't any transmission outside the ship. We think this was acquired in Argentina, probably from contact with rats. Maybe more than one person was a case, and then spread within the ship, within the close contact within the ship. We didn't get any spread outside the ship, and that's testament to the many teams involved and all their work on them. So very rapid run through, but just wanted to flag up the amount of uncertainty, research, evidence generation that goes into these responses. And I just want to leave with huge thanks to all the teams involved, but particularly the cases contacting their families who tolerate not only our control measures, but also all of the research and evidence generation that we do alongside it. Thank you.
Global networks and partnerships are in my blood, and it's something I love, that way of working. So, and I know that you all enjoy working in partnership as well. So I'm going to talk to you a little bit about this global partnership that is now 10 years old. I'm very much talking on behalf of the Mental Health Research Network. I'm one of the co-leads with Professor Tolene Sodi from South Africa, the University of Limpopo, but now the network has really grown, as you will see. So that gives some of the background while my slides came on. So just as a background, our partnership focuses on mental health in Africa and mental health inequalities, and amongst African diaspora and communities here in the UK as well. And, you know, as in many parts of the world, Africa is dealing with rising mental health issues, crises, and conditions, especially amongst young people. Most African countries have very high young populations, so a lot of the work focuses on adolescents and young people. And of course, many of the health systems are weak, you know, they're not well resourced, so there are often not very good services. So, and there's many other challenges that they're also trying to address: food insecurity, conflict, you know, poverty, rapid urbanization, etc., etc. So, and as in many areas, mental health continues to be underfunded, and mental health services are a neglected aspect of healthcare through the continent. So the Pan-African Mental Health Research Network, which I shall for short call the network in future, okay, is a collaborative research and practice network established to address long-standing gaps in mental health knowledge, services and policy affecting Caribbean and African populations. The network brings together universities, researchers, mental health practitioners, and community stakeholders across sub-Saharan Africa, the Caribbean, and the United Kingdom. And in fact, I think the next slide shows you that some of the membership that we have now. We started with 3 partners, and we're kind of really growing now. And so we have South Africa, Uganda, Ghana, Nigeria, Kenya, Zimbabwe, and then Caribbean, West Indies, and Guyana as well. Now, it's not that, and Ethiopia, I should say, and it's not that we're just trying to collect, you know, as many countries as we can. It's about, you know, the people who are doing the work, and that we are working with to support them doing that work. So it's a support network. And interestingly, Nottingham-Trent was, you know, at first the sort of main convening UK network. A lot of people were saying, well, why is, you know, you're doing this work in Africa, why have you got Nottingham-Trent there? But actually, one of the things we recognised, and increasingly is being recognised, and other universities are coming to work with us in the UK, is looking at diaspora communities in the UK and mental health issues. So and the learning, you know, across both sides, you know, is also around collaboration and learning. So a core purpose of the network is to advance research that engages critically with Indigenous knowledge systems, community practices, and lived experience. This includes challenging stigma, expanding mental health literacy, and improving access to care in contexts where systems are often very poorly resourced or even don't exist at all, or inaccessible. So we function as a platform for dialogue between formal mental health systems, such as universities, hospitals, and policymakers. But as we all know, actually, healthcare is simply the tip of an iceberg. And if you look underneath the iceberg, there's actually a whole ecosystem of services, informal services, and they might be private, they might be civil society, they might be NGOs, international, a whole sort of range, a whole ecology of different stakeholders, if you like, but who all play a vital role in everyday kind of mental health support. So through its activities, we aim to influence policy and practice and strengthen academic capacity across the partner institutions. And that's a big part of what we do. But the approach that we come from, we position mental health not only as a clinical issue, but we come from the social model of health, where we position mental health as a social justice concern shaped by inequalities, shaped by colonial histories, poverty, gender, and education and community resilience, all of which intersect across each other. So recognizing that real complexity that shapes how mental health is played out across the countries that we work with. So by fostering equitable partnerships and shared leadership, and I'll talk about that a little bit more, we seek to rebalance knowledge production and contribute to more inclusive and effective mental health services for African and Caribbean communities. So that's what we're trying to do. So as I said, we've got a wide range of institutional partners. And in fact, it's becoming so much bigger now that actually we're beginning to form different chapters. So we have a UK chapter where we're meeting actually this Thursday in Manchester. And then there'll be an East African chapter, West African chapter. So it makes it easier for people to come together aside from the big meetings. We have a monthly meeting, which is online every month. And then, we try to get funding for knowledge exchange activities, dissemination purposes, conferences, all that sort of thing. But in between also have these more local activities. So yeah. But all these institutions contribute local expertise, contextual knowledge, and long-standing engagement with community mental health challenges. So, for example, our Caribbean partners at the University of Guyana and the University of West Indies in Jamaica extend our network's reach to share diasporic and post-colonial experiences of mental health. So, so the partners bring, those kind of specialities in the work that they are doing and really add to what we're trying to do. So rather than operating through a hierarchical governance, we emphasize shared leadership, mutual learning, and respect for diverse forms of expertise. So, for example, we rotate the chairs every 3 months, for example. And we also work very strongly and really support our early career researchers. And they are very much the lifeblood of our work. We really value their perspectives because they bring in fresh ideas, challenge to our thinking, innovation, and many of them are here today. And, now sitting in my position as Emerita, a lot of my work over the last few years has been around nurturing and supporting and bringing forward, those young researchers who are going to be leaders of the future. And, I think that's part of our role in public health, is to nurture and bring forth the new leaders for the future. So, and we very much have peer-to-peer support mechanisms for the early careers, but also they're also mentored by senior academics as well, but we give them responsibility, you know, and you see them grow in, you know, in confidence to really come forth. So by linking institutions with different resources, histories and strengths, we hopefully create a very collaborative ecosystem capable of addressing mental health challenges across a whole range of settings while resisting extractive research practices, which I'm going to talk about now. And you probably all know, having just used that phrase, where I'm going with this. I'm going to talk about decolonizing. I'm sorry, I'm just going to skip through some slides for brevity. Very nice little quote there from one of our early career researchers in South Africa. Okay, so I'm going to talk about decolonizing research, which is really important to kind of understand. So we have an explicit commitment to this. This approach challenges the dominance of Eurocentric models that often marginalize African and Caribbean ways of understanding distress, healing, and well-being. So very often we export the Eurocentric perspective on mental health, for example. And yet, you know, if you're in Africa, you see it differently. So trying to understand that. So we try to promote research that's accountable to the communities that we work with. We engage stakeholders throughout the research process. I heard people talking about collaboration and co-production, and, you know, the starting point is the community, actually, and working from the bottom up as far as possible, and from defining priorities and methods to interpret findings and sharing outcomes. Actually, we have on the South African faculty, they actually have a traditional healer who is a member of faculty. And so we have often held, you know, workshops with traditional healers to try and, you know, work with and understand, you know, their views, their worldview, views around mental health and their experiences. So, and we're also trying by doing this to reduce power asymmetries between academics and communities by valuing lived experience, oral knowledge and indigenous practices alongside formal scientific methods. So then that begins to inform what you do and how you do it, and also what you're looking for as well. So, so I had a PhD student of mine who, you know, was working with some communities out in Ghana, in very rural Ghana. And, you know, first of all, before she could even engage with doing any research, you know, she took part in the singing and the storytelling that was so important, actually, for kind of setting the scene for the community to work with her. And that was really, really important. So co-learning and reverse innovation are also central principles, allowing insights developed in African and Caribbean contexts to inform practice and policy in the global north. And that's about learning from each other. There's, I don't know if any of you know Sir Nigel Crisp, who worked in government for many years on partnerships, and worked actually with the Tropical Health Education Trust, where we got a lot of our, some of our funding from in our other partnerships. But he talked very much about turning the world upside down, being able to look at things differently, but also to learn from that and think, well, what can we apply here? What can we do differently? So important. So this approach supports more ethical, relevant, and sustainable mental health interventions, we believe, by bridging formal and informal systems of care. We create space for collaboration between clinicians, traditional healers, educators, and community leaders. And ultimately, you know, the framework seeks to transform not only mental health outcomes, but the way research itself is done. And of course, there is a whole history, a littered history, as you will all know, of people going in and just extracting data, you know, doing the research and then leaving with that data, and it never goes back to those communities. So, and then I think we were talking about that, about community research here in the UK as well. So, so I can see that maybe, how much time have I got? Another 5 minutes? No, no more 5 minutes. Okay, all right. Okay, so let me go ahead just to finish then. Future vision and growth. So looking ahead, we want to expand our reach and, you know, work with people around developing culturally appropriate mental health solutions, broadening our partnerships in Africa and the Caribbean, deepening engagement with policymakers, and securing sustainable funding. And of course, in the current climate, funding is a difficulty. But, you know, if you have a way of working in partnership that has these values, where where you really value, you know, who you're working with and the values, etc., then actually you can survive the funding gaps, you know, so that you don't fall apart during the funding gaps, but actually you use that time to do other things as well. So, so that's where I'm going to end because of time, but I hope that's okay. So thank you very much. Thank you.
This works great. Put it where you want.
So welcome,
Thank you.
and thank you for
Thank
waiting
you.
until last. We've been
Yes.
eagerly waiting.
So I cannot blow fresh air and fan you. What I can do is be fast, very, very quick. So first of all, big thank you to, this was supposed to be a festival. It's now people collapsing under heat. There is a very nice paper about whether we can be trained for heat and climate change. I beg to disagree. But thank you very much to Arpana and to Greg, who has been a very inspirational vice president for the Global Health section. Greg is back there and refusing to come down here. So please clap for him very loudly. Thank you. Thank you very much. Very quickly, you heard some of the things. First of all, my apologies. I was not planning to do slides, but then I saw the room and I thought you should have an anchoring point. And then this blew completely the order, but perhaps it's better because I can be briefer. So I'm the current president of the Global Health section, and please be more involved because at some point I will need to step down. I have very good vice presidents, but still we need more people. I'm academia, but I was for many, many years R&D, and I come from oncology. So public health is second specialty for me. And I'm very, very passionate, have been for 20, 25 years for primary care and community care and informatics too. And when I say 20, 25 years is a long time. And I think this is how, for health information, some of us got to meet together. It was a matter of having common language. So I wear many different hats, and these are my own views, not necessarily the views of many others. I'm very, very happy. And again, thanks to Manchester, but also the Global Health section team and everybody else. If you scan the top QR code, this became an academic conference. So we're very, very happy because we had peer review and we have published. So the supplement was released earlier today. You can find it by going to the European, yes, thank you very much. So you can find it by going to the European Public Health Journal page by scanning the first link. I also want to say that we partnered earlier in the year in October because for women's health, for gender-based violence, for safety, not only security, but safety in its broader perspective with health promotion aspects, with health in and for all policies. We partner with Eurosafe, so we also had another supplement that you can also find and see there, similar themes complementing this from a different perspective, social work. I think we didn't discuss as much as we would like today, mental health and social work, so sincere thanks to the last speaker, because this was global health and mental health. And I mean, let's face it, everything can be wonderful. If the mental health is not good, you cannot really enjoy anything else, and it's really neglected and misunderstood and so on. So, very important. Farhang and many other people mentioned, before I go there, also something very important, you will find in this, the first editorial piece that many people and Greg leading crafted, something which may be perceived, misperceived. It is very important to remember that knowledge is a public good, and that means not as a public good, but is a public good. So that means access. So it is honorable. It's one thing to try and say that we're doing the right thing. It's another thing to involve people and provide access. And access means having people at no cost, or at least low cost, being able to attend academic conferences. And this is not at all what we're seeing. So decolonizing, sure. Interdisciplinary, sure. Intergenerational, sure. But nothing really matters if you end up having really very big blocks, blocking blocks in terms of funding, in terms of access, in terms of, you know, for medics, some of you are medics, in terms of being able to attend a 3 or 4 day conference. So this is what we try to change here. So thanks for that too. That was made possible from all of us. So going very quickly, there's lots of things that are being discussed and were discussed today for polycrisis and permacrisis. I think we know very well that we are in an era of normalized uncertainty, and we each come from different pockets. So you heard very interesting thing, but maybe difficult for non-epidemiologists or non-molecular epidemiologists for hantavirus and other things. And you heard things about climate change and you heard things about GBV, but really, all of these things coalesce and come together, and they have some commonalities. And this is where we hope we can all meet in public health and in global health, irrespective of what our area of focus is. And of course, it's highly specialized as we go along. And in this respect, we have a situation where we have normalized uncertainty, where we need to have a different type of skill set, and where, of course, we're discussing continuously data and evidence and so on, but the evidence cannot ever be complete. Very often it can be generated, but not timely, you know. And the decision-making that we have to do can only be legitimized if it's transparent, if it's well-reasoned with the data that we have at a given point in time. And in this respect also, the public health task has to be transparent judgment under, you know, changing conditions. And there you heard politicians and policymakers speak. It's not quite the same. And it's important to mention that because we are at a time where we have two very big issues. We have securitization, and we have a big discussion about resilience. And there are two different types of resilience, two forms of resilience, and they're presented as mutually exclusive. So will we invest in infrastructure and in medical services and over medical assets, or will we invest in prevention? Rather than go hand in hand and see how much you can avoid and how much you can factor in. And this is a little bit important to consider as scientists, irrespective if you come from clinical medicine or public health, epidemiology, because more often than not, we see a tendency to make decisions on the basis of funding schemes, of research being funded, and we see the evidence being contested. And public health has become very politicized. I have been, because I'm UK trained, I have been following what's happening with post-COVID analysis discussions in the parliament, and not only, and in the US, of course. There was a colleague earlier today that said this was in the post-Trump era, but we are still in the Trump era and the pre-Trump era. So things are becoming very, very difficult with resources being shifted to very specific, let's say, security-related aspects. And I think, generally speaking, for global health for some people is travel medicine, and for some other people is geopolitical dynamics, and for some other people is epidemiology. But for us, it was there was one common overarching theme, and you heard some things mentioned by Tina, and some things mentioned by Farhang, who's of course ethics, and some things by law, and that is we need to examine how we can reach evidence-informed policy making in a transparent manner for all of these topics, and how to maintain a policy-making workforce at different levels that is informed and can participate and enable these decisions. And in this respect, a crash test, if you like, and failing miserably, and you heard some about these things, is the women's health. Women's health, I am at the moment post-surgery and going through surgical menopause. And as I said, I come from oncology, and I can tell you that we have 50,000 femtech apps with digital tools and AI and a lot of medicalization and a lot of prevention. And we see that we have exclusionary policies because of fees. We see people giving away their data without realizing what they're doing. We see colonization of data, which is a very nice, new, funky form of colonization. And we also see many people saying the things I say, but for the purposes that are not, let's say, so well-meaning. So we see narrative and advocacy groups advocating for rights of women or for rights of children or for climate change and so on, but for purposes which are not necessarily the purposes that we would have in mind in public health when saying safeguard public health and maintain welfare for people and so on. And the difficult aspect there is whether we can ensure we stay up to date with things like genomics, with things like informatics, with things like ethics, because that is also evolving. The questions are fundamentally the same. They haven't changed in the last 3,000 years, but how we make the decisions, how we involve communities, this is transformed and it could be better achieved. So at the moment, if you look at outcomes, if you look at catastrophic payments from health economics, and if you look at women being left behind, since SDGs were mentioned, we're not doing very well. Tomorrow and the day after, we have, in Paris, we have UNESCO conference for 10 years of SDGs and science. And somehow, strangely enough, the UN has not much on health there because science is engineering and many other things. So we have also a little bit, let's say, of pathology on how our UN system is set up. And it's important to remember that we also have cross-sectoral things were mentioned in NCDs, irrespective of how the verbiage changes. I saw only 3 or 4 hands today raised when NCDs were mentioned. We keep on having mistakes repeated. NCDs and communicable diseases do not live in siloed boxes. We've seen this in COVID, and if this lesson was not learned, then that's a disaster, not ethical or unethical. So the people that are suffering from NCDs are the same people that were disproportionately affected in communicable diseases, which brings us back to commercial determinants, brings us back to very basic, let's say, traits of what determines poverty, exclusion, socioeconomic status, and so on. And of course, as I said, critically for women, we see they are disproportionately affected. It sounds a bit pedantic, but it's the same for climate change and the same going forward for digital technologies, because we see lots of, let's say, not very well established forms of employment being completely taken out, or people losing jobs because there's no protection with what's coming with further automation and jobs which are really being taken over by new technologies. Now, I don't want to be too long, but different words were used over the day. So I added this slide over lunch. Different words were used today to actually describe this. And this is something also we were discussing in Infodemic. So I don't know, I do not know how many of you, this is from a mathematician, that the map and the territory, the map is not the territory. And maybe you are familiar with the image from a grid or not. This is important to remember because we may construct different maps, epidemiological maps, GIS systems, and so on. But evidence synthesis determines some of the futures for which we can collect evidence without involving people in the field and the people in communities. There was a very nice thing mentioned by the previous speaker. He said, I'm not an expert, I do not do clubbing. And this is the people in the territory. So you need to involve the communities. And at the moment, the communities are not involved. This is also critical because, you know, we look at the policies, we do policy analysis. We did it for migration. I mean, we did it in my country for shortages. We say we have now screening population, but if you look at the policy, I mean, yes, we have access, but if somebody lives 500 kilometers away from the nearest center for having biomarker testing, that is not being measured. And if you're a woman and you're taking care of children and of parents, and maybe you're a man doing the same, but okay, traditionally we're doing a little bit more, let's say, in this respect, you are disproportionately affected, and the policy is irrelevant because you will simply not take advantage of it and nobody's measuring. And we see this more often than not happening with unpaid care, with lack of access because of linguistic barriers, but now we're also seeing digital things, digital literacy, and so on. Having said that, I do not know if people are aware that 10% of people in Europe do not have internet. That's 10%. That's over 50 million. Talking EU, of course, but I think, and then if you want to talk metrics, and we say we have shortages, we discuss shortages at the EMA very often, but the United Kingdom had over 500 million waste in medicines, and Greece had exactly 1. That is stuff that was, you know, procured, it was dispensed, it was bought, it was covered, it was never used, which is really scary figures. So all of this data have to become policy somehow. And there comes a difference between politics and policymakers. And you cannot eliminate political judgment from the decision making. What you can do is be involved enough as academia or as science or as public health to ensure there's not selective or misleading use of evidence and information, which is happening galore at the moment. And I think Pitt mentioned trust, and populism was also mentioned. It is an era for that. This was always there. It's just now becoming much more prevalent and much more extended, let us say. And it does affect public health largely, because there is an aspect of social welfare, providing for the masses and also providing for people that may not be able to generate income in an era where we keep on discussing sustainability, economic development, competing dynamics, and geopolitical dynamics. So there is another domain that we should keep in mind. I think, don't know how many of you heard, there is in the biomedical community, there's a lot of panic at the moment for Europe and for the US, because in the first half of 2026, China already spent 110 billion in biomedical research, particularly for drug discovery, which basically means that in the next 10 to 20 years, it's unlikely there will be anything innovative left. And this, of course, it's something you have to factor in, because it means access for innovation, for public health perspective, will have to be safeguarded by accessing via Asia. So whether we like it or not. So these are the figures. And then last, but certainly not least, we are trying to change a little bit things at the EUPHA, the European Public Health Association section. This is a very dense slide, and it is AI generated. But it is also there to take a look at what needs to be done. So we do have scarcity, it decides partnerships, and it means coalitions, and Tina mentioned that a lot. It means that it's important to look at whether evidence is turned into policy. It means that it's important to work cross-sectorally, and it also means that for misinformation, we need to move a little bit beyond communication. It's being presented as a communication issue. We think it's a fundamental issue of data and evidence and information, and we think the community there is critical. And last but not least, and I'm trying to be very fast, all of you know what the NHS is. Yes? Is there anybody that doesn't know what the NHS is? Yes. You heard of Aneurin Bevan this morning by Tracy, because we were having a chat. Is there anybody that didn't know Aneurin Bevan? Can I have hands up for those that knew who he was? Okay, a lot of you knew. Do you know how he got inspired to do what he did? Did he magically, he had nothing to do with health. Do you know how he came about, did what he did? Has anybody heard of Treggerize? Yes? Treggerize. Yes, yes. Nobody talks about that. This is the essence. So there was a community. There was an effort at community level, and people got together and they paid little pences to have something. And they started with 20 people, it went to 300 people, and that was the blueprint. And this was late 19th century. So we're talking about 150 years ago. And this is where Bevan got inspired to do that. And it was very limited resources. We're talking much fewer resources than we ever had. And the peak of transforming in Tredegarizing, the term at the time was Tredegarise. I think we should be teaching that. When I was 30, I'm 53 now. At some point we got taught that, but no longer. So at the point where this was peaking in terms of NHS for prevention, including very important oral protection, dentures and things like that, which are never mentioned or considered prevention, and they are prevention for GI tract and not only. This was post-war UK. It doesn't get any poorer than that. It doesn't get any more destroyed than that. Similar situation in Japan and in many other countries. It's just perhaps NHS was the most shining example, and this was why it was shining so much in the Olympics as well. But the foundational basis and the answer was in the communities. It was people coming together and participating to transform. And then this is how he got inspired to do this. So we don't really know, we know some of the people that were active in that, but whose initial idea was to put people together and do something like a social mutual fund to ensure safeguard health of the community. Nobody knows, but you can see the effect. The effect is unbelievable and it's massive, and it started with much fewer people than we have in this room. So this is important to remember for the communities. It's very nice to see Manchester saying community in its educational programs. I add primary care because we're very passionate about that, and also because pragmatic trials and transformative public health can also come from that. And last, but certainly not least, if we have to stay with one message, stay very, very positive. get much more involved, including for partnerships, but also in your own domain for finding out historically what has happened. Usually everything more or less has happened before. Maybe the parameters are changing, but the lessons are there. And please feel free to reach out and be more involved with the section on what we're trying to achieve. Thank you. And sorry for speaking very fast.
Yeah, I want to say thank you to this amazing team who've brought you back to Manchester year after year after year. You can see the dedication to public health. In Manchester, we take our responsibilities as a university very seriously in terms of local and global societies. So we're delighted you're all here discussing it. But amazing that this team is still dedicated to bringing you all together to that. So thank you. I get the honour of celebrating some of your brilliant presentations. We can't celebrate all of you, but thank you to all the amazing work we've heard today. Really important challenges, really important solutions we've heard.
Thank you so much to Joe. So we have moved schools and division. This morning you would have seen Tony, but Joe is our head of division. And we wanted to say a huge thank you to you and the team, because you really embody what public health and community medicine is all about. And you are an honorary public health person.
I am.
But I hope today has been just the start of a beautiful time together. So thank you, Joe. Well done to our winners. A huge thank you to all of our speakers, all of our oral and poster presenters, our workshop presenters, all the fabulous exhibitors, and for you as the delegates. But I have to say, what an amazing team we have who have pulled together today. Very pleased to say that the HDRC Manchester team are with us. And we have a new website that we are launching today. And we have our supplement, as Elena said, this is now live. So your abstracts, if you accepted all those different things that you had to approve, is now on the European Journal of Public Health's website. If you are on LinkedIn, I've posted the HDRC website as well as the website for our supplement on there for you to have a look at. But huge thank you for bearing in this heat and poor air quality. Huge thanks for staying with us and for us being running over. That's the word I'm looking for. I do have a plea from Greg to join him in Big Hands. For those of you that don't know Manchester, you just walk onto Oxford Road, turn left, and it's just on your right after the Student Union and the car park. So huge thanks. Please give yourself a round of applause and see you next year.